Greetings and thank you for joining us. My name is Maribel Hernandez. I am a cardiologist at Lancano Heart Institute and medical director of the Women's Heart Initiative. The Women's Heart Initiative is a program that was developed to encourage women to learn the truth about heart disease and the risk it poses, and to use this knowledge to make informed decisions with your healthcare providers to get the best and equal treatment and to live healthier lives. We're all here tonight to discuss an important heart health topic, cardio-oncology. What to know about your heart before, during, and after cancer treatment. If you have cancer, you might not be thinking about your heart, but it is important to know that certain cancer treatments, including chemotherapy, may cause harm to the heart and blood vessels. Today, I have the pleasure to introduce two amazing physicians from Mainland Health. Doctors Artie Chevay, who is a medical oncologist and hematologist and a member of the Alliance Cancer Specialists at Lancano Medical Center. Dr. Kate Hawthorne is a cardiologist with the Lancano Heart Institute, and she's the medical director of the cardiac MRI program and shareholder of the Ernest Scheller III Chair in Innovative Cardiology. She's also clinical assistant professor of medicine at the Sidney Kimmel Medical College, Thomas Jefferson. Welcome to Dr. Chevay and Dr. Hawthorne. And I believe that Dr. Chevay is going to be starting.
So thanks for having me and thank you for the introduction. It's great to be here tonight to talk about what I think is a really important topic. Kate, you can go to the next slide. So let's just briefly, talk about, what exactly is cardio-oncology. We talk definitely about it more and more within oncology itself. However, I think it's important for our patients to understand what this is exactly. So essentially, it's an emerging subspecialty within cardiology, and it's primarily comprised of cardiologists who have developed an expertise in cancer treatment-related heart problems. And as was already mentioned, different cancer treatment modalities can cause cardiac dysfunction. And this can really lead to a major cause of both morbidity and mortality in the oncologic population. Now, cardiac complications can arise as a result of radiation therapy, chemotherapy, but we're even seeing it as a result of newer treatments, which include targeted therapy and immunotherapies. So advances in cancer treatment have been we've made great progress specifically over the past decade. And as a result, we're seeing more and more survivors, and cancer treatment is really allowing more people to survive the disease. But of course, it does unfortunately come with a bit of a cost. Cancer therapies can injure the heart, they can injure the blood vessels. And the goal of cardio-oncology as a subspecialty is really to try to prevent and treat these potential problems before, during, and after cancer treatment. So currently, there are 18.1 million cancer survivors in the United States. This comprises about 5% of the population. So the number of cancer survivors is projected to increase by approximately 25% to 22.5 million by 2032. So over the next decade, the number of people who have lived 5 or more years after their cancer diagnosis is projected to increase approximately 30% to 16.3 million. I put this slide up here simply to reiterate what many patients already know, that breast cancer is the most common cancer in women, and prostate cancer is the most common cancer in men. And that's followed by lung and colon cancer. You can go to the next slide, thanks. So the cancer mortality rate has decreased continuously since 1991, which has resulted in an overall drop of 33% and approximately 3.8 million cancer deaths have been averted. And this is largely in part due to reductions in smoking. More and more people are also getting screening tests. So that includes things like mammograms. Patients are getting their colonoscopies, and they're getting them at a younger age. And of course, there have been improvements in treatment. More and more, we're using targeted therapies and immunotherapy. And this is something that's really started really over the last decade. So let's start with a little basic background. So what exactly is cancer? We know that it is a disease in which some of the body's cells grow uncontrollably and spread to other parts of the body. It can start almost anywhere. Normally, human cells grow and multiply to form new cells as the body needs them. And that's a process called cell division. Now, sometimes this typically orderly process breaks down and abnormal or damaged cells grow and multiply when they shouldn't. These cells can form tumors, and cancerous tumors can spread into, invade nearby tissues. They can invade into these nearby tissues. They can even travel to distant places to form new tumors, and that process is called metastasis. So in terms of cancer treatment, I think it's important just to get a very basic sense of where we started and how far we've come. So cancer treatment years ago really was simply surgical. So a tumor arose and it was removed, and that was sort of the extent of it. And then in the 1900s, radiotherapy was developed. In the 1940s, we had the development of chemotherapy. And then more recently, in the 1980s, and then over the last decade, we've seen the development of targeted therapies, monoclonal antibodies, and most recently, checkpoint inhibitors. And checkpoint inhibitors are also referred to as immunotherapy. So how does all this work? So how do the different modalities tend to work? Well, basically, chemotherapy is targeting cells at different phases of the cell cycle. So chemotherapy is stopping or slowing the growth of cancer cells, which can grow and divide very quickly. It can be used to cure cancer in certain cases, especially with things like lymphoma. Chemotherapy can actually cure the cancer. However, oftentimes we're using chemotherapy to decrease the chance that it will return. It's also, in some cases, being used to simply slow down the growth of metastatic disease, or when a cancer has spread to multiple locations, then chemotherapy is being used to control the disease, but not necessarily cure the disease. So if you look at this cartoon here, what you're seeing is that in the upper part, you can see that cells that are healthy, they divide, and they divide in a uniform fashion. But cancerous cells, what tends to happen is that they're dividing uncontrollably, and oftentimes those cells are quite damaged. So not only are they dividing rapidly, but they're really pretty dysfunctional. And so what chemotherapy is aiming to do is interrupt the proliferation or growth of tumor cells at the process of cell division, or when they are dividing rapidly. That's where chemotherapy is trying to stop that rapid growth and proliferation. This leads hopefully to cancer death and allowing, however, healthy cells to remain. In terms of immunotherapy, this is a whole different way of fighting cancer, but it's a significant breakthrough in cancer therapy within the last decade. It tends to be better tolerated as compared with chemotherapy. What it's really doing is harnessing the body's own immune system to fight cancer. However, one of the rare and serious side effects of immunotherapy is cardiotoxicity. So specifically, when we're talking about how exactly immunotherapy works, is what it's doing is if you look at a tumor cell, so tumor cells bind to T cells, and T cells are a normal part of your immune system. But tumor cells, when they bind to T cells, they cause the T cells not to work properly. Immunotherapy drugs are blocking tumor cells from deactivating T cells. So what immunotherapy is really doing, it's allowing your normal T cells to actually fight the cancer cells. So when it comes to cardiac disease and cancer, why do we need to discuss this? Why is this important? Well, we know that these are really two of the most common disease conditions in the developed world. And it's important to consider that cardiac disease may already pre-exist cancer therapy, or could or may be caused and exacerbated by it. So while cancer therapy is becoming more and more effective than ever and leading to, more survival, it is coming at a price. So in any patient, heart disease and cancer are likely to overlap. And the key here is keeping in mind that both cardiovascular disease and cancer is typically seen in our older population. So it's quite common to see a patient who already has an existing cardiovascular condition, and now they have a cancer diagnosis. So more and more, we're gonna really have to rely on our cardiology colleagues to help our patients get through their cancer treatments, but also to be mindful and aware of how our newer treatments could impact their pre-existing cardiac disease, or it could lead to a cardiac complication years down the road. So with that, I'm going to pass this on to Dr. Hawthorne, who I think is going to be talking about the more specifics of cardio-oncology.
Thank you, Dr. Shavde. What an impressive field. I think one of the most fascinating pieces, just being, even a little bit exposed, is how far cancer therapy has come, and how good of a job we're doing with treating those cancer patients, to the point that many of these cancer patients are then going on to die from cardiovascular disease. And whether or not that's related to their toxicities, we can discuss a little bit more. So because this is the Women's Heart Initiative, I do have to throw out some facts about women and heart disease. So I'll veer off course for just a second. And this is a very busy slide and we won't go through every single point, but I just want to remind women and the people in the audience that cardiovascular disease is the leading cause of death for women in the United States. And really only 44% of women recognize that. So just by being here and educating yourself, you're already taking that step forward and acknowledging that risk exists. Among women over the age of 20, almost 45% have some form of cardiovascular disease. So getting back to Dr. Shavde's point about that overlap, many patients are going to go into their cancer therapy with some form of cardiovascular disease, whether it's hypertension, coronary disease, heart dysfunction, or valvular heart disease. There's really all kinds of shapes and sizes, but many patients are coming into their cancer therapy with some underlying issues. I'll skip over some of the pregnancy piece, which is near and dear to my heart, and just want to point out that there are many disparities within cardiovascular disease and cardiovascular risk factors. So we know that hypertension, which affects many millions and millions of Americans, affects Black females almost disproportionately compared to other races. And so really, as we're thinking about just general women and cardiovascular disease, it's really something that affects many of us. And there's a whole lot that we need to do in this realm, as women are often excluded from research trials and things. So to kind of get back into topic a little bit and think more specifically about cardio-oncology, really the goal is to help patients with cancer therapy receive this amazing care that has been afforded to them. So these drugs are incredibly effective in treating their cancer. So we want to make sure that they can receive these medications or these treatment options, and we want to try to minimize any cardiovascular toxicity. So it really depends on the underlying patient. Some patients should be would receive benefit by coming into a cardio-oncology program before treatment is even started. And that's somebody who may have underlying cardiovascular disease. We know that patients who have underlying cardiovascular disease are more likely to have one of these complications from their therapy. They're just a higher risk patient. So we're gonna make sure they're optimized, that we have an appropriate surveillance plan in place for their treatment therapy. During treatment, if a cardiac complication occurs, and we'll go through a couple different complications, we want to make sure that we detect that early. We start treatment and get you back onto your cancer therapy. And then long-term follow-up. So some of these toxicities can occur years later. So we want to make sure that if a patient has received one type of treatment that may have a lingering effect, that we do appropriate surveillance. So who can benefit from a cardio-oncology evaluation? You know, of course, again, it's that population of cancer patient who has an underlying cardiovascular issue. We want to make sure that they're being appropriately treated and best optimized going into their therapy. Any patient who develops a heart symptom while receiving their cancer therapy is, and you know, another person who would benefit from seeing a specialist to assess those risks and again get them back onto therapy if appropriate. And then cancer survivors who may have had issues from their therapy or who may have long-term damage caused by their cancer therapy. I have a bunch of slides. I don't want to run through the nitty gritty. I'm really just kind of want to use them more as discussion points. So I threw up 2 slides. This is really a rapidly growing field, and there have been some guidelines that have come out to just help us think about this very specialized group of patients. So this was just one nice pathway, and really it is largely broken down by the underlying cardiovascular risk of that patient. So it's very individualized care. And this is where the true expertise really comes into play. So an oncologist like Dr. Shevday is going to meet with the patient, of course, discussing their cancer, but also thinking about their heart risk. And, you know, many patients are going to fall into this low risk category. And depending on the therapeutic agent or modality, there may be a surveillance plan, and I have a couple of outlines just to show you some things. And then really, these are patients who lifelong should always be having their cardiovascular risk assessed, or if they received a therapy that could cause risk, following that surveillance. It's really more this moderate or high risk patient. Well, maybe they should be seen by a cardio-oncology specialist to just help think about their risk with their oncologist and make sure that we're doing everything we can to optimize them, optimize their heart medications and their status, and then just kind of reassessing along the way, looking closely for symptoms and serial monitoring. So really a lot of how we decide who gets what monitoring treatment depends on the underlying risk of the patient. And there's really the table on the right side of your screen, again, is not to run through all the nitty gritty, but to just kind of show you that there's really a lot of pieces to that puzzle when we think about a patient at risk. So this was a chart that is used for baseline assessment in someone who's going to receive anthracycline chemotherapy, a very common chemotherapy we use for breast cancer. And so we go through an algorithm. Okay, what's this patient's risk look like? We often, we will get baseline echocardiograms to look at their ejection fraction. Is their ejection fraction normal or abnormal, which would put you in 2 very different buckets. What's the underlying demographics and risk factors for this patient? What's their age? What do they have underlying comorbidities? And so there's really a lot of thought process that goes into treatment and surveillance plans. When we think about some of the risk factors that go into it, again, just kind of trying to simplify one of those extensive tables, a lot of it is the state of the patient going into treatment. Do they have high blood pressure, diabetes, high cholesterol? Smoking increases your risk of cardiovascular complication, obesity. Sedentary lifestyle is really an important factor. Someone who is active going into treatment is likely to have a better outcome from a cardiovascular standpoint. Have they had any prior treatments we need to keep in mind? Did they receive radiation in the past? Have we previously used cardiotoxic chemotherapies? That's going to, again, impact how we think about them, how we stratify them and monitor them. We might think about different medications to use even prophylactically or before something negative occurs, just in order to best protect them. And then what are some of the complications we may see during treatment? So an abnormal heart rhythm or an arrhythmia. We can see narrowing of the heart vessels, either in the arteries of the heart or more distal vessels, like something called peripheral arterial disease. We can see damage to the heart valves, especially using high doses of radiation to the chest that might be used for, say, Hodgkin's lymphoma. We can see weakening of the heart muscle or something called heart failure. We can also see inflammation, especially with some of our newer agents. They can cause inflammation of the heart sac called pericarditis, or inflammation of the actual heart muscle itself called myocarditis. And this is just an illustration that talks about some of the different therapies that we have seen that can cause some of these complications. Oftentimes, these are things that we're going to know to think about, and we're going to ask questions. So your oncologist is going to ask you about any, palpitations or pain, or difficulty breathing, swelling, different symptoms along the way, blood pressure checks, because some medications can raise the blood pressure. So all things we're going to be looking out for as a team, and make sure that we identify these things early and treat them so that we can get the patients back on their cancer therapies. I just threw up an anthracycline surveillance protocol. So you can see there's really a lot of pieces of the puzzle. So we're gonna look at EKGs, electrocardiograms. We're gonna look at echocardiograms or TTEs along the course. Different blood tests are recommended. And again, it really depends on what risk category you fall into, how much surveillance is recommended. But there are thankfully guidelines. These are coming from the European Society of Cardiology, but as this field has grown, there have been many more guidelines and recommendations put together by teams of experts. And then again, thinking about long-term surveillance. So this is going to certainly vary agent to agent, so I couldn't possibly put together a list, but in a very simplified form, long-term surveillance is going to be recommended for some patients with some treatment strategies. And so oftentimes our low-risk patients may not necessarily need long-term surveillance if they're low risk to begin with. Of course, every year we're going to want to make sure we check in on their cardiovascular risk, because now that their cancer is cured, cardiovascular disease is a looming threat and something we want to make sure that we're treating. Those higher risk patients, we may be doing monitoring periodically with echocardiograms or different screening tests. So a lot of this is going to be very individualized. This is just another example if we're looking at someone who's had chest radiation. That's one of the biggest complications we can see from a cardiovascular standpoint, especially some of our higher dose, more centralized radiation strategies. So there's a whole algorithm of things we're going to be thinking about, yearly screening and physical exam. Is there something new? An EKG, a new heart sound? It might, defer us towards looking at different screening, like an echocardiogram or cardiac MRI if we are suspicious of something very concerning. So different strategies based on individual assessment year to year based on their therapies. So just a summary slide. Who can benefit from cardio-oncology? Well, I certainly think the team approach improves outcomes for all of our patients. Our patients have better care when we work together. And so cardio-oncology is really a hallmark of a team-based approach with multi-discipline, really spans oncologists, cardiologists, nurses involved in care, coordinators. There's really a lot of people who are involved, and it makes for a great team. And so patients who either have underlying heart problems, who are going into their cancer care, or those who are at risk, patients who develop cardiac symptoms along the way, or patients who maybe fall into that higher risk category, are certainly patients who can benefit and would be recommended to seek care with a cardio-oncology team. So I ran through that really quickly, my apologies, but I did want to make sure we leave some time for questions.
Well, thank you both, Dr. Shefde and Dr. Hawthorne, for these really great presentations. And I certainly also learned a lot today. I have a question. Let me see if we have any other questions. No. Well, I'm going to start with a question. If you had breast cancer treatment many years ago, like in the 1990s, how far off do you need to be seeing a cardiologist years later? Can you have effects of chemotherapy? How late can you have effects of chemotherapy and may need evaluation?
Yeah, so that's a great question. And there are certain chemotherapy agents that we use. The one that's most often used is adriamycin, and that one can cause, interestingly, it can cause issues with heart failure acutely, subacutely, or even years later. So I think one of the important things moving forward is, what happens is a lot of our patients, they'll see us for maybe 5 years, maybe 10 years after their treatment is done. And then oftentimes they will stop following with us and will start to see, continue their follow-up care with their primary care physician. So I think this sort of ties into survivorship planning, which is happening more and more in oncology now, where patients meet with a survivorship team after their treatment is done, just to say, hey, these are the medications or the agents that you received, and sort of like follow-up guidelines. And that is really becoming more common. But I think the bottom line is some of the issues can be seen years from their treatment. So you sort of have to have a high index of suspicion if you're thinking that something is going on that might be related to prior treatment. So we also have to educate our primary care physicians about all this in the future as well.
And a lot of it can vary too. A woman who received left-sided chest irradiation plus adriamycin may be at higher risk for some of those complications. And depending on the dose of adriamycin, we know there's a dose-dependent relationship with which most of our oncologists are staying below that dose, so we start to worry. But what if it was a recurrence or a very concerning lesion? That patient may have received higher dose, and that's where, again, it's really individualized by patient. So these survivorship plans, I think, are going to be so tremendously beneficial for this type of patient to go back to her survivorship plan and say, okay, I received 500 of, adriamycin, which would be a considered high dose, and maybe I should have regular screening or meet with a cardio-oncologist, as opposed to, someone who didn't have that high a dose. So I would never discourage someone to start thinking about their heart health, and certainly that woman could start with her primary care physician, and if they're not comfortable, refer them off to a cardio-oncologist. So just, even if it's a one-time visit and they say, hey, nope, I think you're all good, just, work on your preventative cardiovascular piece, great.
Agree. Yeah, it's really important for a lot of these patients, especially now, as we mentioned, people are living longer and longer. And being cured from their cancer, but then sort of left to deal with some of the outcomes of their therapies. So,
and even if it's not their therapy, we always encourage preventative visits. So we can focus on the non-cancer things.
Yeah.
I think you both alluded to one of the questions from the audience. I mean, if my oncologist did not refer me to a cardiologist, can I just be proactive and schedule an appointment with one?
I mean, I don't see a downside. I think there's no, unless you both disagree, but to your point, you already mentioned that just there's risk from other things besides just, chemotherapy or cancer related. So there's really no downside to being proactive and going ahead and making that appointment.
Yeah, I agree. I mean, I think even I have plenty of patients outside of cardio-oncology who just say, hey, I turned 65. I felt like I should see a heart doctor.
Right.
Say, like, you are so healthy. I have nothing to offer you. Great. Come back if there's any issues. And that's an okay visit. Oftentimes we find things, hey, your blood pressure is a little high or your cholesterol is a little bit off. I feel like it's never a waste of time. We usually can kind of just run through their general cardiovascular risk and find something that we can do to optimize their cardiovascular health. So I would never discourage that.
Yep, I agree.
And Dr. Hawthorne, I saw in one of your slides about how often to get echocardiograms, which is for the ultrasound of the heart to monitor the heart function and during chemotherapy. And if you could review that by looking at the slide that you showed, is if you're actively getting chemotherapy and chemotherapy agent that may affect the heart function, and you're on the higher risk category, it appears to be every 3 months or every third treatment of the cycle of the treatment.
Yeah. So
for someone who's high risk, how often should they have that?
So I think from a patient standpoint, that's very individualized. So I would chat with your oncologist. I feel like the oncologists are great at following those guidelines as far as frequency go. You know, certain chemotherapies like the Adriamycin or Herceptin or trastuzumab require more frequent screening than we might do for others, certain chemotherapies. So there is defined recommendations for screening, and some are quite frequent, particularly I feel like with the Herceptin and Adriamycin combination. But there are very clear definitions. And I'm happy to chat with you, Dr. Hernandez, if you're interested in some protocols. There's
Yes.
the European Society of Cardiology guidelines are really nice, just in kind of laying it out to make sure that, you know, they go through different agents and recommendations, and it's still pretty vague as far as who is considered high risk. There are some guidelines. There's a lot of different tools that it seems people use, and Dr. Shevde, you can fill me in if you've got something that you kind of go to, but it seems like a lot of it is somewhat subjective as far as how patients fall into those categories.
Yeah, I agree. I mean, there are certain things that we definitely do. There are very strict sort of guidelines on. So for example, you mentioned Herceptin or trastuzumab. So guidelines are very clear. You get an echo pre-treatment, and then you get an echo every 3 months while the patient is getting or being exposed to that agent. So that's probably the most, I guess, like, it's very clear cut what we're supposed to be doing. There's really very little room for debate on that. But with all the other agents, it's really kind of subjective. And I think it's important for us as oncologists to kind of risk stratify these patients sort of even before we start treatment, just to kind of have a sense like, okay, yeah, this patient is sort of high risk or this patient is low risk, and then just kind of keep that always at the forefront. And if there's anything concerning, to really refer to you guys, you know, sooner rather than later.
Any other questions? Let me check. Okay. Well, I just want to make a comment that as a physician who's been in practice for many years, it's great to have now this cooperation with the cardiologists and oncologists to really prevent cardiac complications. And that has not always been available to the patients. So we're very fortunate to have physicians like yourselves and hospitals and health system like Mainland Health, who really are trying to have the oncologists and cardiologists working together to really prevent complications from cancer treatment. Well, I want to thank both of you for taking the time for this webinar. For the audience, if you have any questions related to your heart health, our virtual webinars, or if you want more information about the Women's Heart Initiative, you can email us at women'sheart@mlhs.org. And thank you. And remember, we are available for questions. And again, our email is mlhwomensheart@mlhs.org.
Great. Thank you for having us.
Thank you.